Hello, everybody. We'll give it a few minutes. I know there was another session before this one. We'll give it a few more minutes and see if anybody else joins. I know the other session was still going. Okay, so I just got a message that will start in about 20 minutes because the other session is still going. So I'm gonna go ahead and turn my camera off for a few minutes and we'll be back in about 20 minutes. They said the other session is still going. So this one will start in 20 minutes. All right. Good evening, everybody. This is Dr. Lapage. We'll go ahead and get started. And if people join, then we'll just catch them up if we need to. So, can you all see the screen? Great. Good. All right. So I've posted the PowerPoint so y'all have access to it. Let's talk about our objectives. Upon completion of this presentation, the participant will be able to identify the pathophysiology, etiology, and clinical features for meningitis and head injury, evaluate the findings of particular labs and diagnostic studies used to diagnose these neurological disorders. And particularly, we'll talk about lumbar punctures and those procedures used to diagnose those neurologic disorders, and what is the nurse's role in assisting with those procedures. And then identify the nursing interventions and how to prevent complications of these neurologic disorders, and then incorporate um, some medication therapies to the treatment of these disorders. So, first, we're going to talk about meningitis. What is it? Well, it's an infection that we all know that causes swelling and inflammation to the meninges, which are at the base of they're throughout the brain, but most commonly at the base of the brain, and that fluid accumulates around the brain and the spinal cord. Um, it can be viral in nature or it could be bacterial or fungal. Viral is kind of self limiting, and because it's a viral infection, we don't necessarily treat it with antibiotics unless they have a coexisting infection. A lot of times, some strep throat and some of the organisms can cause some meningitis, and it would still be viral, the viral meningitis, but we would treat the infection that caused it. It can be life threatening in some instances, and if it's bacterial, we treat it with antibiotics, and if it's fungal, what it'll be treated with antifungals, but it's required, or in order to save the patient or the obtain the best outcomes, we really need to start treatment as soon as possible. So these patients need to be seen as quickly as possible. Particularly, we're talking about childhood neurological disorders, so it would be the children. Makes it kind of difficult to diagnose because they really can't say, my neck hurts, this hurts. They're kind of irritable. So think about those signs and symptoms and the differences between children and adults, because children typically get meningitis as well, especially the younger ages. So that brings us to the risk factors. What are some risk factors? Some chronic medical disorders. These would be more so for the adults, your renal failure, diabetes, cystic fibrosis. But remember, we can have infants born with renal failure and renal disorders as well. Extremes in ages. So, again, those young babies, and then the older population. Those under vaccinated population, immunosuppressed patients, transplant patients are very susceptible to getting meningitis. And then those congenital immunodeficiencies, those babies born with HIV infection, could be very prone to developing or contracting meningitis. Sometimes exposures and risks could be a risk factor. Travel to some of those areas. Southwestern US, we typically see those bacterial cocci disease organisms, excuse me. And then northeastern US, we typically see the Lyme disease that can cause it. Sometimes mosquitoes can be those vectors as well as ticks. I have taken care of patients who have had severe tick bites that have progressed to meningitis as well. Some dural defects, sickle cell anemic patients can be prone to developing meningitis. And then those patients who have had splenectomy for whatever reason can be prone to meningitis because remember, anytime they have a splenectomy, they're more susceptible to contracting infection. So, the etiology, the most common bacterial causes of meningitis in the US are Streptococcus pneumoniae, Neisseria meningitis, and then those Haemophilus influenza disorders, and then Listeria monocytogenes. We typically see Listeria in our undercooked foods. So, the pregnant mom who eats something undercooked or raw could have listeria. Listeria would be the organism. So, what are our signs and symptoms in children? Again, remember our signs and symptoms in adults are going to be a little bit different. Our children, we're going to see that high fever. They're going to be constantly crying, very irritable. They could be very sleepy. So, how do we really diagnose that? How do we trend those sleep patterns? Because remember, infants are small children are tend to be more sleepy during the day, and more often they sleep more hours in the day. Sometimes they may have some trouble waking up from that sleep or getting them to wake up. They're not as active when they are awake and sluggish. Not waking to eat. They're not eating, so their appetite, they're a little um, suffering from anorexia and not wanting to eat. Poor feeding, they could be vomiting, and then we could see some bulging fontanelles in the baby's head. Stiffness in the neck. When they move their neck, they may cry more so, and trying to differentiate between the cries. Is it just an irritable cry or a painful cry? That can be kind of difficult for some new parents. And when we see meningitis, we typically see it in infants less than 3 months old. So, signs and symptoms in the adult, again, they're going to have that high fever. Um, they get that stiff neck. They complain of really bad headaches and severe nausea. They could have some confusion, trouble concentrating. So, identifying the differences between adults and children, we need to be a little more cognizant of their different irritabilities and then their crying. They tend to get a really high pitched cry, which is indicative of severe pain in these infants or children. So, what are some complications? Think about these children and these infants are developing a lot of these. So, a complication could be hearing loss, trouble with seeing. But again, a baby doesn't develop um, the ability to identify and see completely until they get older. So they're not going to be able to verbalize what's going on. May have some memory issues. Some of our younger children, they could develop some learning disabilities long term, and then brain damage, trouble walking or delay in walking, and then seizures, kidney failure, septic shock, and ultimately death. So we really want to prevent that. The complications can be very serious. And the longer someone has the disease that's undiagnosed, the more their chances of suffering from long-term complications becomes. So again, think about those developmental stages of the babies and the infants when we're diagnosing them and our children, and what could be the complications of those. An infant with less than 3 months old with a fever greater than 100 is considered a medical emergency when you're coming into an emergency room, and those patients are brought back right away. How do we prevent it? Because again, those babies, we're going to definitely have good hand washing, trying to stay healthy, pregnant mothers making sure that their meat is cooked, and then vaccinations and anybody around the baby being vaccinated. Washing hands before they touch the baby. If anybody's sick, making sure they're not coming to the house, especially if it's a newborn, when the baby is, or when anybody is sick, and because you don't want the baby to get sick. And prevention is going to be that prevention that we do for any disease processes and any newborn. Making sure that the formula is not old and making sure that mom is washing her hands before she breastfeeds or prepares that formula. So it's a lot of education on the nurse when they're discharging the parent with that newborn. How do we diagnose it? Well, with your CBC, and what are we going to see? Well, when we see the CBC, we're going to see elevated white count, obviously. Our electrolytes may be abnormal. We may see some hyponatremia. Clotting times they would do as well. Blood cultures to identify the organisms, and then possibly a lactic acid. They may do cultures of the throat, of the nose, to further identify any coexisting infections. And then see cerebral spinal fluid analysis by a lumbar puncture. They can do some radiology imaging, but you really need to take a look at that CSF fluid and send that to the lab. So the radiology imaging is just going to show, especially your MRI, if there's any swelling at the meninges, and the X-rays and the CT scan might possibly be for chest or sinuses to identify any coexisting infections that these patients might have. So, our treatment, we're going to use broad spectrum antibiotics, and especially until we get the culture results back. But again, we know those take 24 to 48 hours. Acetaminophen for that fever. Sometimes they give corticosteroids for the swelling and the inflammation. Definitely want to increase their fluid intake. Let these patients rest as much as possible, and then pain medication if needed. They might give them some pain medication for the headache, but again, if it's an infant, and then gauging what is that pain level can be somewhat difficult. So, as far as nursing interventions, we're going to provide safety. These patients do get isolation and they do go on droplet precautions because it is a droplet spread infection. Administer those antibiotics, allow those periods of rest. So we're not going to go in the room and do 20 different interventions. We're going to give this baby time to rest. We may come in and take the temperature and the respiratory rate, and then we may have to come back and get the rest of the vital signs. We may not come in, do vital signs, administer meds, and do an AM care and a bath on this baby. We might want to need to give them those periods of rest. Again, that procedure is going to be the lumbar puncture, and the nurse's role, we don't particularly we don't perform the lumbar puncture, but we do assist. We do help with positioning, we do maintain that sterile field, and we do retrieve all the necessary equipment for it. So getting used to or identifying where that equipment is in your facility and knowing what comes in your lumbar puncture kit is really essential because that's the nurse's role. Any questions so far? Oh, good. Congratulations, John. He said, or she said, all glory to God. I passed NCLEX. Many thanks to Naxlex. It's very useful. Congratulations. Great job. Study hard. Tips are study hard. You never know where the questions are coming from. And believe in yourself. You got this. That is very true. Very true. Because those questions can be anywhere. Does anybody have any questions so far about meningitis? Okay. So let's talk about lumbar punctures and what is our role in it. So it is a diagnostic test. Again, it is performed by the physician. The purpose is to either test the pressure of that cerebral spinal fluid or analyze that cerebral spinal fluid for infection. There are some contraindications to performing it. If there would be an infection at the insertion site, you would not want to perform it. If there were any lesions at the insertion site, if the patient had severe thrombocytopenia, or a severely increased intracranial pressure. Now, remember, anytime they have any illness in the brain or in the spinal cord, they're going to have a little bit of increased intracranial pressure, but if it's severely increased, the landmarks for performing it or where they're performing it at is L4 through L5 in an infant. The reason being is you don't want to go too high up on the spinal cord. Again, nurses need to know where, but um, I mean, assisted the physician in performing many lumbar punctures. It's just a landmark, and I had to research and see exactly where to do this presentation because it's not something I believe NCLEX would test you on because we don't perform it. What they would more so test you on would be the position you're going to put that patient. So that patient could either be side lying with their knees drawn up toward their head, or they would be, if it's a baby, you would you want to expand that spinal space or that spinal column space. So you may have that baby um, laying on their side lying and kind of curve their knees all the way up. You want to get them as close to their chest as you can because that's what's going to increase that space in that spinal column. Um, Positioning is important during and after. After the procedure, you want this patient to lie flat for at least 30 minutes to an hour because one of the biggest complications is a spinal headache. We also, as far as feeding prior to the procedure, there is no particular instructions for the patient to be NPO or nothing by mouth except if they're going to use sedation. They typically do not use sedation in lumbar puncture except at the site. So they will inject the site or in, inject with some lidocaine to numb the area, but a systemic conscious sedation they typically do not do. Feeding post procedure, we definitely want this patient to increase fluids because we want to keep them hydrated and we also want to replace that cerebral spinal fluid that was removed. Um, Anytime we get samples, we walk those samples to the lab, and it is the nurse's responsibility to label them and to walk them to the lab. A lot of facilities will have what we call the pneumatic tube system, where you can put lab specimens in this pressurized tube. If you ever, years ago, we used to have them at the bank at the drive throughs. Now, with all the new ATMs, but they're pneumatic tube systems and they're pressurized and you push a button and the tube will go with high pressure to wherever you send it to. Remember, anything that is not easily retrievable as far as specimens must be walked to the lab, and that's typically a policy for most of your acute care facilities. So your cerebral spinal fluid would be walked to the lab. Any stool specimens would be walked to the lab. The emergency room I worked in, any pediatric blood draws had to be walked to the lab because they're not easily accessible or easily retrievable. Any questions? lying flat, prone, or not prone, they're lying flat on their back. They're not gonna be in a prone, well, yes, that is no, proning. They would be supine on their back. Prone is on their stomach. They're not gonna be on their stomach. Any other questions?
Okay, this way. No, this way, this way, this way.
Are you asking a question or are you talking to somebody? Okay. So, complications of a lumbar puncture, again, that severe lumbar spinal headache. They can develop a hematoma at the site, or the site can cause bleeding. The size of the needle, it is a spinal needle, it is much longer, and the gauge is bigger. It's a wider needle so that they can get that cerebral spinal fluid out. These patients can get infection. What do you think might cause an infection at the site or in the spinal column? Anybody know? What would be the cause of an infection during a procedure like that?
Can you show your screen, Professor?
Yeah, I was asking a question. What would cause an infection during a lumbar puncture?
If unsterile items are used, not washing hands, washing sterile gloves, or the field that the procedure is being performed is not sterile.
Exactly.
Yeah, thank you.
Exactly. Thank you. Poor aseptic, absolutely. Somebody asked, what is the priority nursing interventions post spinal tap? Well, what do you think might be the priority?
Positioning the patient.
Yes, keeping them flat for the first 30 minutes to an hour, and then monitoring for any bleeding as well, or a hematoma, or signs of infection. Plus, we don't want any spinal fluid leakage either. So, monitoring that site and then keeping them flat to prevent that lumbar headache. Monitoring for any hematomas, bleedings, and then they can have brain herniation, which is very, very rare, but it is a complication, and then a spinal hematoma. We would diagnose that herniation or that spinal hematoma with a CAT scan or an MRI. Infection would obviously be by monitoring vital signs, and we're going to do that frequently. Somebody asked, what's the best place to take a temperature on an infant? So, most facilities require, and it's the best, a core temperature is always the best. So, and that's rectally. That's the only way to get a core temperature. Some facilities have policies that anybody under the age of 2 require a rectal temperature. Again, if the parents refuse, then you take it whatever way you can. I know post COVID, everybody started using the temporal thermometers, but they're not exactly accurate. So, with a child, especially if we're ruling out meningitis and it's an infant, you want to get a rectal temp. Our adults, we get rectal temps if they're a septic patient or somebody who we cannot get a good oral temp. Your axillary temps are not very accurate. There's a lot that could factor into that, and the temporal ones are not as accurate as well. If these babies are very, very sick, they may, and adults too, they may put in rectal probes and for a temperature, and they will continually monitor their temperature, and it's hooked up to the monitoring machines. Does anybody have any questions on meningitis or lumbar puncture so far? Because we're going to move on to head injuries. So no questions? Okay. So let's talk about head injuries. That could be damage to the scalp, to the skull, to the brain, or to any blood vessels of the head or area. A head injury is often called a brain injury or a traumatic brain injury, depending on the extent of that injury and often too how it occurred. So there's a couple different types of head injuries. There's your concussions, that causes the brain to not work normally. Sometimes it's for a short period of time, sometimes it's for an extended period of time. It can result in loss of awareness or alertness, can sometimes cause some altered level of consciousness, not to the obtunded or to the comatose factor, but some mild, a lot of lethargy we see. Contusions is a bruise on the brain. It can cause bleeding or swelling inside the skull, which could further cause damage and increase intracranial pressure for these patients. A lot of times we see contusions with motor vehicle accidents, especially those whiplash injuries where the patients are hit from behind, which is why to prevent head injuries in children, we wear helmets to ride bikes and scooters, and we put them in car seats that are approved and that help support their head as well, and also keep them rear facing until they're 2 years old. Skull fractures can be several different types. You can have a linear skull fracture, which is just like a break, and again, it's like a line. Those bones don't move. Um, Sometimes with these linear skull fractures, we watch the children at home. Sometimes they're hospitalized. It depends on how severe it is and what their symptoms are as well. Um, Shaken baby syndrome causes those contusions, and then dropping the babies or hitting the babies in the head can cause those different types of skull fractures. Typically, the babies that are dropped or the babies that are hit in the head for due to child abuse develop or have those depressed skull fractures where part of the skull is so sunken in and that bone is broken on top of it. So they don't necessarily have to have a laceration to the head or a cut to the head to have a depressed skull fracture. It's the actual skull bone that gets fractured. Um, Diastatic skull fracture, that's going to occur along the suture lines in the skull. They're kind of jagged, and so those bones kind of are not going to fuse together correctly as they grow. Um, Normally, the suture lines are widened, but these tend to fuse together as they grow. Um, we see the diastatic more often in the newborns as well. And again, it depends on the injury. We see typically skull fractures have to do with abuse, unfortunately, especially in infants. Those that we see that um, are a little older and able to roll is because they roll off the bed or they roll off of a hard surface. A bibasilar fracture is a break in the skull bone at the base of the head. So that's a pretty serious skull fracture. Um, children of children and infants, they'll get, if they have a bibasilar skull fracture, they'll get the bruises around their eyes, and we call them raccoon eyes. It will be bilaterally, and they'll have bruises around the eyes, and they'll come in and they look like raccoons. Patients with basilar skull fractures will typically have some CNS leaking, either from the nose or the ears. Um, and that's where part of the brain kind of tears off from the skull bone as well. Those patients are definitely watched very closely in the hospital. We watch for any increased intracranial pressure on them and any changes in LOC. What can cause these types of injuries in children as they grow? Well, we see a lot of concussions and contusions with sports injuries, especially our football players or our baseball players that get hit in the head. Um, Basilar skull fractures and those diastatic fractures we see from them falling, especially if they're on a high surface and not supported and they roll off, or if they are dropped, or unfortunately child abuse. Motor vehicle accidents, or patients who are pedestrians and being struck by a vehicle while walking. And then we talked about child abuse and abusive head trauma where they're hit in the head. Unfortunately, we see that a lot. We are mandatory reporters, so any suspected child abuse does get reported. So, what are some signs and symptoms? Again, those signs and symptoms are going to be a little different in the adult versus the child. Again, it depends on the age of the child if they can tell us that they have a headache. Sometimes they're photosensitivity or they cry a lot when you put the lights on. That severe nausea and vomiting or that projectile vomiting is in the infants and young children is a clear-cut sign. Abnormal behavior and a lot of irritability. They just can't get comfortable. When you lay them flat, they're having a lot of pain, so these babies are crying a lot. Confusion, lightheadedness, and dizziness. Again, you have to think about the age of the child that they may ask you about and then correlate those signs and symptoms. May have some difficulty concentrating. They may complain of ringing in the ears, the tinnitus. What we see in our infants is a lot of lethargy and loss of consciousness. And then if it's a bibasilar fracture, you may see some changes in respirations because remember, our respiratory center is at the base of our brain. As your children get older, you may have some slurred speech and a lot of CNS changes and symptoms. They may progress to seizures and convulsions. And in your infants, too, that may be, unfortunately, that's what we see that they bring the patients in because they've had a seizure. And that's when they get diagnosed. Sometimes if it's the parent or somebody else that's abusing the child, the parent sees the child seizing and brings them in, and then we wind up getting diagnosing it with could be some abuse. Um, One of the other things that is pretty common, especially as they age, these patients get what we call locked in syndrome, where it's a condition where the person is conscious, but they can't talk and they can't speak or they can't move. So they're just kind of staring at you with that blank stare. And it's called locked in syndrome. We had a working in the ear, he was a 12-year-old that had come in with a gunshot to the head. The story, it was mom and stepdad, and the story they gave us was that they were upstairs. The kid was in the kitchen. They were fighting because he got in trouble and they were taking his phone away. And he went downstairs or upstairs to his room, wherever. And the next thing they know, they heard a gunshot. So they went up there and the patient was found with a gunshot wound, is the story they told us. Well, the patient came in cardiac arrest. We got the patient back, but there was a bullet hole in the front of his forehead. And we were obviously saving this child's life. He was in cardiac arrest, but some of us were like, how could he point the gun and get that perfect um bullet hole and it not be anywhere else in the brain? The mechanism of injury and how it occurred and what they said just really didn't make sense. Well, we got the kids stabilized. The children's hospital was coming by helicopter to pick the 12-year-old up and take him back to the children's hospital because RER was not a children's hospital, but we were the closest facility. The children's hospital is about 45 minutes drive time, and depending on traffic. So we got him stabilized. He was on the ventilator and everything was good. And we were kind of cleaning him up post the arrest. And we realized there was a pool of blood in the back of his head. And when we turned the patient, there was actually an entrance wound in the back of his head. And the wound that we saw on the front of his head was actually the exit wound of the bullet. So subsequently, the stepfather got arrested in the ER for shooting the child in the back of the head. So sometimes you just never know. You got to look at the different symptoms. It did make the news here in our city, and he did get arrested and spent, I know he got sentenced to 25 years, but I don't know the outcome if the child ever survived because one of his pupils was already fixed and dilated. So that is, once the patients have fixed and dilated pupils or one fixed and dilated pupils, it's a very bad head injury. That is one of the signs of a bad head injury. Does anybody have any questions?
Yes, just a question, Professor. So, like for a child abuse, would you go, if you're supposed to report a child abuse, would you go by just reporting it as a nurse, or would you go by the chain of command?
So we are mandatory reporters. So yes, it depends on your facility and where you're at and what their policy is. As the ER, we as nurses can report it. We don't have to go up the chain of command. We do have to involve the physician. There have been incidences where the physicians don't want to report it because they want to stay out of it. And as a nurse working in the ER, we can report it. And some nurses have. So it's I guess it just depends on what the policy is at the facility you're at and what area you're working in.
Got it.
I had she said she had 2 or 3 farm questions. So diagnostic testing for head injury is going to be an x-ray will show a skull fracture, but your CAT scan and your MRI are going to show more detail, and show the CAT scan obviously will show you if there's intracranial bleeding. The MRI would be even more specific with the MRI or an MRA, which is your magnetic resonance arteriogram, where they actually can see the blood flow. So if they're testing patients to see brain function, or if the patient is brain dead and doesn't have any blood flow to the brain, they're going to do an MRA. Some neuropsychological testing would be very specific testing, and probably once the patient has been discharged on an outpatient scenario for that neuropsychological testing to see where they're going to go from there. I have had patients, this was an adult that had come in. He was in his 60s. He was in a assisted living. He got brought into the ER because in the group session he had a bad outburst and threw a chair. Doing further investigation and talking to the patient, he had a traumatic brain injury from a car accident that caused him to have these outbursts that he could not control. So it was kind of sad talking to the man, because he will not let his son bring his grandchildren to see him because he doesn't know if and when he's going to have an outburst. So that neuropsychological testing and neuropsychological treatment could possibly help that patient. Thinking about your children, think about some of the, injuries that could cause some neuropsychological dysfunction. They may develop ADD, they may develop some other issues. So getting that neuropsychological testing is pretty important. Unfortunately, not a lot of insurances cover it, and it is quite costly. So treatment for head injuries, why do you think we don't want to give them narcotic pain medications? Why would we avoid narcotic pain medications with a head injury?
Yeah, head injury, I think already it has already affected it has altered the mental status. So when we give narcotic, it will depress the respiratory center, and therefore it will affect the breathing.
Yes, it can affect their breathing. It can further sedate them. So are we assessing the sedation, or are we assessing the head injury, right? So we don't want to give them any medications that can alter their level of consciousness or their breathing, like you said. We want to provide rest periods for them and try and get these patients to rest. Avoid overstimulation and overexertion. So maybe dim the lights in the room. Keep them off the computer, off the games, off the iPhones, which would be very hard with some children, right? Ice, if it's just a minor injury or a bruising or a swelling, we'll give ice. And then depending on how severe it is and how bad the head injury is, these patients may require mechanical ventilation, especially if they're having those bibasilar fractures and it causes severe head injuries and it affects the respiratory center. One of the things, and or if it is a spinal cord injury on top of that head injury, one of the things we also want to talk about and look at with our trauma patients who are either in motor vehicle accidents, a lot of diving accidents, a lot of kids on scooters without helmets, we want to protect that cervical spine. So anytime we assess the airway on these patients, we're putting on a C-collar and supporting that spine and that C-spine until we get an x-ray and make sure that there is no fractures. Any questions? All right. So what are some complications of head injury? Well, it depends on the severity of the injury. They could have a traumatic brain injury and be comatose and debilitated for long periods of time. They may have some minor muscle, speech, vision disturbances. They may have some personality changes. They may develop some permanent disabilities, spinal cord injuries, paralysis, and then ultimately death. So, again, think about the severity of the injury and then what could be those complications. They could be long term or short term, again, depending on the severity. Obviously, the more severe the head injury, the more the complications and severe the complications are going to be. Seizures, absolutely. Seizures are a big complication. So, does anybody have any questions on any of the content that we just went over? I do have some questions and case study questions to review with you if nobody has any questions on the content. Okay.
For meningitis, Professor, I know it can be contact and droplet, but if you should see a question and it says meningitis, what precaution would you use? Would you use the higher one as droplet or would you go with the contact?
No, you would use the higher one, the droplet.
Okay.
Yeah, it would be droplet. Absolutely. Because contact is just protecting basically you, but we need to protect everybody because it would be droplet, especially while they have the fever. And they are considered contagious for 24 hours after the fever is resolved, or 24 hours after the antibiotic. So they may not develop, or the fever may go away and then we start the antibiotics, but they need to be on the antibiotics for 24 hours and or fever free for 24 hours before they're not considered contagious.
Okay. Does it cause meningitis? Does it cause ICP? Sorry, meningitis.
It can. So those good neuro assessment. At what angle do we elevate a patient with a TBI? At least 30 degrees. Good question. We don't want to lay them flat, especially if they're on the ventilator and they're intubated. So that might be a question as well. What are you going to watch for with this patient who has a brain injury and is mechanically ventilated? Remember, mechanical ventilation can automatically increase ICP. So these patients, as nurses, we're going to have to do very good neuro assessments on these patients. Oftentimes, if they're mechanically ventilated, they're also sedated somewhat, right? So we need to be checking those pupils. We need to be checking for any agitation or any changes or any signs and symptoms that will indicate changes in level of consciousness. Good question. Restlessness, absolutely. Restlessness, irritability in your children, or if they're like, we call it bucking the vent when they're setting off the high pressure alarms. They're either waking up, which would be a good time to get a good assessment, or they're getting very agitated. They may have tremors that would indicate they're having seizures. So you really want to watch for those too. Bacterial meningitis, yes, it is droplet. If you are the healthcare worker taking care of somebody with bacterial meningitis, a lot of times they will put you on, and we don't know it because oftentimes these patients come in and then we do a lumbar puncture and find out that it is bacterial meningitis. They will put us on antibiotics prophylactically, typically ciprofloxacin for I think it's 1 or 2 doses um prophylactically. I had a young girl, she was 16, 15, 16, and she really did not come in with signs of meningitis. She was a cheerleader, she had fallen, she had some neck pain, it had been previously, she was feeling really run down, but she had no fever. Had strep throat a couple weeks ago, previously, and mono had been going around her school, so we ruled out the physician ruled out everything. But she still was not feeling better, and we couldn't come up with any diagnosis. So the doctor did a lumbar puncture, and she wound up having bacterial meningitis. So we all wound up taking Cipro for I think we took 2 doses. But sometimes you just never know. Once you rule out everything else that you think it might be, then you do the meningitis and rule out the meningitis as well. Will the patient have nuchal rigidity? They most often will. However, it's kind of difficult to diagnose in an infant. Remember in the very beginning, I kind of talked about how the babies may be more irritable when you lay them down or move them because they can't tell you my neck hurts. They're infants, right? So kind of watching for that. Any other questions? All right, so let's do some questions. The nurse in the emergency department has been put in charge of several clients. Which of the following clients should the nurse escort to a private room first? I see lots of bees. Yes, that is correct. Some patients will develop that red macular rash. Photophobia, again, and that rash are classic signs of meningococcal meningitis. Um, Again, it is highly contagious, and we need to put these patients on droplet precautions. What is the treatment of choice for that? Do y'all remember? Nobody wants to take a guess at it? Antibiotics, broad spectrum antibiotics, absolutely. Flank pain and vomiting is indicative of what? It's easier if you all tell me what you think. Then I don't have to keep switching back and forth to the different
That could be
screens.
could it be the kidneys?
It could be
Kidney stones.
pancreatitis.
Kidney stones or pyelonephritis. Yep. What about what could be wrong with the client who fell 1 hour ago and whose right arm is longer than the left arm?
Fracture.
It could be a fracture or it could be a shoulder dislocation, right? When we see that asymmetric, when they're not symmetrical, they're asymmetrical. Oftentimes it's a shoulder dislocation. What about the client who had an internal fixation of the femur 5 days ago and is experiencing constant pulsating pain in the left leg? What could that be?
Could that be compartment syndrome?
It's not typically they don't have pulsating pain with compartment syndrome. They have more swelling and that really taut, shiny skin.
Could it be an open reduction, like a broken?
Well, they've already had it. They had a femur fracture. So what's a common complication of a femur fracture?
DVT.
DVT. Yep. Yep. That one's probably a DVT. That pulsating pain in the left leg is a sign and symptom of a DVT. Good job. A 4-year-old client diagnosed with bacterial meningitis was initiated on IV antibiotics for the last 12 hours. Which of the following actions by the nurse is the most appropriate? So again, remember, this is a priority question. So they all could be correct, but which is the best answer?
Put a droplet precaution.
Yeah, why do you think droplet precautions?
To reduce the spread.
Yeah.
Just in case it was yeah, okay, it's been diagnosed already.
Yep. And your key words there are they were already started on the antibiotics and it's only been 12 hours. Remember we said they have to be fever free or on the antibiotics for 24 hours. Right. So the lumbar puncture should have already been done. And that's how we diagnosed them with bacterial meningitis, right? Allow the family members to remain at the client's bedside to offer comfort. Well, he's a 4-year-old, so that's probably correct, but we're going to minimize the number of family members, right? And they're going to have to maintain those droplet precautions. So, and then keep the client in a well-lit room. Remember, with meningitis, they typically have photophobia. We might turn a light on to assess that rash or the presence or absence of the rash, but we're not going to keep that light on all the time, right? Does that make sense for everybody?
Yes, bro.
Yes.
Good. A nurse is caring for a toddler with suspected bacterial meningitis. Which of the following cerebral spinal fluid analysis findings should the nurse anticipate?
A.
Cloudy.
Cloudy.
Yeah.
Is A.
Yep. It is A, right? So they typically, the cloudy means there's infection. CSF fluid should be clear. Typically if it's bacterial meningitis, it's going to consume the glucose. So we're going to have a decreased glucose level in the CNS. And normal CNS glucose levels should be 50 to 80. So that's even lower than our capillary, right? Low protein levels, actually protein leaks out due to the inflammation. So these patients may have elevated protein levels. And then decreased opening pressure, that has to do with the ICP, and they're not going to have decreased, but they may have increased. So good job. It's definitely cloudy. A nurse in the pediatric unit is caring for a toddler 5 minutes post a lumbar puncture. The nurse should place the client in which of the following positions?
D. Knee drawn to the chest.
So
If he has finished the
A.
lumbar puncture, it should be
A.
supine positioned. A.
yes, the correct answer is A. So go back and read that again. This patient is 5 minutes post lumbar puncture. So remember, we want to put the patient supine with the head of the bed flat for at least 30 minutes to an hour to ensure or prevent the patient from getting that spinal headache. Right side lying with knees drawn to the chest would be during the procedure. We don't want to put them prone, and we don't want to sit them up, because that's the opposite of keeping them flat, right? Does that make sense?
Yes, Prof.
Yes.
All right. A nurse is caring for a client scheduled for a lumbar puncture. Which of the following caregiver statements require follow-up? So again, this is a select all that apply. So we're going to have more than one answer choice. And it wants to know which requires follow-up. So we're looking for correct or incorrect answers or statements.
A.
Okay, it's a select all that applies. So there's more than one answer choice.
A. D.
A and D. Yep. Because we don't want them to have two pillows to support the head. We want them to be flat for 30 minutes to an hour. And they don't need to fast for 6 hours before unless they're getting sedation. But very rarely do they sedate patients for that procedure. Increased fluid intake is recommended. The normal diet is fine. And definitely we want to report any bleeding or signs of infection at that procedure site, right? An infant with suspected bacterial meningitis is scheduled for a lumbar puncture. Which of the following landmarks for the procedure is appropriate for this
D.
client?
D.
D.
Yeah,
D.
L4 to L5.
Yeah. L4 to L5. L1 to L2 is too high and could place this patient at risk for spinal cord injury. L2 and L3 again is too high. And then L1 to S1, that space is too low. So we don't want the intervertebral space. So the answer is L4 to L5. And
Prof,
again,
please,
it's
what's
going
the
to,
landmark for adults?
ma'am,
The landmark for adults.
I would have to look that up. because this presentation was on children. But I'm not sure that they would even ask the landmark because it's not a procedure that the nurse does. We only set up and maintain that sterile techniques and handle the samples. I could probably give me a second. I can.
Adult is L3, L4.
You looked it up?
Okay, thank you.
Welcome.
Yeah, it says L3 to L4 or L5. So it's a little higher up for adults. A nurse is assisting a provider performing a lumbar puncture for a teenager. Which of the following positions is appropriate for this client?
B.
B as in boy, yep. They lay on their side and they draw their knees up. That's what the lateral recumbent position is. We also use that position for administering enemas as well. Or the Sims position where they left their lateral recumbent, but then they put the leg over. A 6-year-old client is brought to the emergency department by the father after falling down a flight of stairs. Which of the following actions should the nurse prioritize? So remember, what is the first thing we're going to do?
Is D.
D as in dog. We're going to immobilize that cervical spine. Yep. What order would you put these in if that was an ordering question?
We'll start with C first.
If it was an ordering question, you would start with C, or you would do C next.
We start with D.
Right.
D,
D.
C, A, B.
D, C, A,
D,
B.
C, A, B. Yeah, D, C, A, B.
Okay. So remember with your priority questions, you're going to do, or your ordering questions, you're going to do airway, breathing, circulation, disability, right? So, it would be D, immobilize the cervical spine. It would probably be administer oxygen and then perform a thorough neurological assessment and then obtain further history of the injury. So remember, airway, breathing, circulation, disability. And disability is your neuro. I can see probably D because it doesn't really say this patient needs oxygen, but it typically should be airway, breathing, circulation, disability. Does that make sense? Good. A nurse is assessing an infant with a head injury. Which of the following are late manifestations of increased intracranial pressure?
Bulging fontanelle.
Okay, it's a select all that apply. And the key word there is late manifestations. So late signs and symptoms of increased intracranial pressure. So the bulging fontanelle is going to be one of the first signs. So it's not a late sign.
B, C, D, E.
B, C, D, E. So it's actually C, D, and E. Your lethargy, remember that's one of our first signs. That's typically why these patients are then being brought in and seen. Bradycardia is a late sign. So as the pressure in the brain compresses that brain stem, it's going to affect that autonomic nervous system and cause that bradycardia. The papilledema is that swelling around the optic disc, and then it's going to obviously, you're going to see it, and that is going to be indicative of severe increased intracranial pressure when it's starting to come out to be visual, because remember, your optic disc is inside the eye. So if they're getting papilledema and you can visualize it, that's a really late sign. And then Cheyne-Stokes respirations are also a late sign of increased ICP. But your bulging fontanelles and your lethargy are going to be early signs. Does anybody have any questions on those so far? The next one we're going to do is a case study that's going to have 5 or 6 questions with it. No questions so far? Okay. So a nurse in the pediatric unit is caring for a 1-year-old client. The nurse's note at 8 a.m. notes that the client is brought to the emergency department by the caregivers, who report a 1-day history of fever, irritability, vomiting, and decreased playfulness. They also reported 2 episodes of generalized tonic-clonic seizures accompanied by postictal loss of consciousness. The infant has been refusing food and fluids with reduced wet diapers in the last 24 hours. The child attends daycare and no recent vaccinations. So what are you thinking at this point? What are your things, or what are your signs and symptoms that you're most concerned with?
Dehydration.
Okay.
Naubos ko yung kape ko.
So I heard some noise, but I'm not real sure. I only heard dehydration. Is that the only thing we're concerned with?
Electrolyte imbalance.
Okay. Electrolyte imbalance kind of goes along with dehydration. Go through. Are you concerned about the fever?
Yes, infection.
Okay. Are you concerned about the irritability?
Yes.
Yes.
Okay. How about the vomiting?
Vomiting.
Yeah.
Yes.
He's 1 year old.
Vomiting, fever.
Okay. He's 1 years old. Are we concerned about that decreased playfulness?
No.
No? He's 1 year old.
Yes,
Yes.
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 Yes, those 1-year-olds, they're all over the place, right? He's had 2 episodes of a tonic-clonic seizure. Is that gonna
Yes.
concern me?
Yes.
And
Yes.
that's been followed
Yeah.
by postictal loss of consciousness. That's really
Yes.
concerning me, right?
Yes.
Yes, yes.
And then he's refusing the food and fluids, and he's
Yes.
had wet diapers. So he's got dehydration on top of what are all those other signs and symptoms of? What is it? The irritability, the fever, the decreased playfulness, and the seizures. What are those signs and symptoms of?
Meningitis.
Meningitis. Yep. Yep. So here's his physical assessment. His respiratory, he's got shallow breathing, nasal flaring, and breath sounds are clear. Of that, what are we concerned about?
The nasal flaring and
Okay.
shallow breathing.
Yes, both of them, right?
Respiration, nasal flaring, that's difficulty in breathing.
Yep. So what about his head, ear, nose, and throat? Normal cephaly with bulging fontanelle, neck stiffness, photophobia. His oropharynx is clear. Are we concerned about anything there?
Yes.
Neck stiffness, bulging fontanelle,
Neck thickness,
And
normal.
photophobia.
And
Normal.
photophobia. Yep.
Yeah.
How about cardiovascular? S1, S2 are heard with no murmurs. Pulses are 2+ in all extremities, and cap refill is 3 seconds.
No, okay, good.
Cap refill.
This is good.
That cap refill should be less than 3 seconds, right?
Yeah.
So we're kind of border on that one, right? Gastrointestinal, abdomen non-distended, soft, non-tender, and bowel sounds are normal, active *4.
That's good.
That's one system that's good so far, right?
Yes.
2 out of 3 ain't bad, right? Neurological, he's alert but irritable and lethargic, but responds to stimuli and has a high-pitched cry.
Yes.
Irritable, lethargic,
Lethargic,
cry.
Yeah.
high pitch cry.
All of that is confirming our meningitis, right?
Yeah.
Reproductive and GU is normal for age, so we're good. His skin, he has no rashes or skin lesions, we're good. Extremities, no edema.
We're
Nothing to
good.
be concerned about there, right? Take a look at his vital signs. What's concerning?
Temperature.
Temperature.
The child. How old is the child?
Blood pressure as
well.
Blood pressure as well.
The child is 1.
Yeah. Heart rate.
Heart rate.
Respiration.
It's SpO2.
Respiration.
SpO2.
Yeah, all of it except what?
Blood pressure.
The
Blood pressure, right? We're concerned about all of it except blood pressure. So is that confirming what we thought?
Yes, meningitis.
Yep. So what did we do? Let's recap what we did. We recognized the cues. We hypothesized the cues. And then we analyzed the physical assessment. So when you're studying or when you're answering questions, that's kind of how you should go through these case studies. So his medical history, he was born via vaginal delivery at term. His birth weight was 7.5 pounds and his current weight is 22 pounds and his immunizations are up to date. So complete the following sentence by choosing from the options below. So I couldn't do a drop down, but on NCLEX, when you click on the drop down for option 1, you'll see those 4 answer choices and you'll pick one of those. Same thing for option 2 and same thing for option 3. I'm not that sophisticated to figure out how to do it. So for option 1, what do we think it is?
Meningitis.
Yep. That is evidenced by what?
Fever.
And fever.
Yep.
And the
bulging
fontanelle.
Yep. So we just did what? We just made our plan and our nursing diagnosis, right? So see how these questions that are associated with the case studies go through the nursing process, right? So the nurse reviews the client's medical record. For each potential provider's prescription, click to specify whether it is anticipated, non-essential, or contraindicated. So the IV Cetraxazone 500 milligrams every 12 hours. Is
Anticipated.
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 Aspirin contraindication.
Contraindicated.
Okay, so the
Oxygen.
neoaspirin is
To
contraindicated.
anticipated.
The O2
Contraindicated.
Yes.
is
3.
anticipated. How about draw CBC and blood cultures?
Non-essential.
Anticipated.
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 Yes.
Anticipated.
Yeah.
Yeah.
How about the lumbar puncture?
Anticipated.
Anticipated.
Yep. How about the brain MRI?
Non-essential.
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 Yep. How about the airborne precautions?
Non-essential.
Anticipated.
No, it's
Anticipated.
No, it's
No,
droplet.
oh, droplets,
That's
droplets,
airborne.
droplets.
It's not. It's non-essential.
Sorry.
It's
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 non-essential
non-essential.
Droplets here.
because it's
Yeah,
not
it's
Droplets.
droplet precautions. So how'd y'all do?
So the brain MRI is not essential.
Right. There's your answers. So the ceftriaxone is anticipated. The aspirin is contraindicated because the child is 1 year old and it could cause Reye syndrome.
Reye syndrome.
Yep. The oxygen is anticipated because his pulse ox was low and his respiratory rate was high. The CBC and blood culture is absolutely anticipated. The lumbar puncture is going to confirm what we already suspect. And then the brain MRI, remember we said we don't necessarily need that because we need the lumbar puncture to identify the organism. And then it's not airborne, but it's droplet precautions. So airborne is non-essential, it's too much, right? He doesn't need that negative pressure room, but he does need droplet precautions. So our physician orders, you can see them at 8:30. We have a couple added: droplet precautions, seizure precautions, monitor neurostatus and vital signs every 30 minutes. So the nurse is preparing the client for a lumbar puncture. Which of the following are the contraindications for the procedure?
I think B and C.
Infection at the puncture site. B. And then
So is it
and then the hemorrhage. C.
BCD.
And then the severe thrombocytopenia. There is already this thing there.
okay? So we don't think it's contraindicated in Guillain-Barré, right? Actually, that's how we diagnose Guillain-Barré. We also can sometimes perform a lumbar puncture to diagnose a subarachnoid hemorrhage. So it's not contraindicated in A and C, but it is contraindicated if there's an infection at the puncture site, if they have severe thrombocytopenia, right, because of that risk for bleeding, and then if they have increased intracranial pressure. Because remember, performing that lumbar puncture can further increase that increased intracranial pressure. And we know this patient doesn't have severe increased intracranial pressure because of the signs and symptoms, right? So our 9 a.m. nurses notes, the client is initiated, that should be O2, at 1 liters per minute via nasal cannula. IV fluids are initiated and ceftriaxone is administered. Acetaminophen was given. Blood samples were taken for the labs, and the client remains responsive to stimuli. The lumbar puncture was performed without complications. Parents were reassured and droplet precautions were initiated. You see his vital signs. Do we see any improvements or deterioration there?
Improve SPL, oxygen improve.
Improvement.
Yeah, that
Blood
oxygen
pressure,
improved.
blood pressure
The-
improve.
Yeah, the respirations came down, the blood pressure's improved, and that temp is down too, right?
Yes.
So when you're given like 2 sets of vital signs, you should start formulating that in your brain. Is it improved? Is it worsened? Or did it stay the same, right? So you see our lab results. Let's look at that hemoglobin white count and platelets. Anything we're concerned about?
Nope.
No? You're not concerned about that white
White blood
White-
cell
White blood
count.
cell is consigning. It's
The
Yeah,
affected.
the cloudy
Okay, well, we're doing the hemoglobin, white blood cells, and the platelets
and
first. So the white blood cell count. How about the electrolytes? Anything we're concerned about?
no. So
Those are all normal, right?
Yes.
We're not concerned about the electrolytes. How about the CSF analysis?
Cloudy.
cloudy.
That's all right.
It's
Where?
cloudy.
Cloudy,
Yeah,
yes.
it's
What
cloudy.
about the WBCs?
High.
It's
It's
high.
high. What about the
High.
protein?
Glucose.
High.
Protein.
It's
High.
high.
Even the
What about the
protein.
glucose?
Low.
Is low.
Okay, it's
Is
low.
that what we suspect with meningitis? Low glucose? Yes.
Yes,
Yes.
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 In meningitis, low glucose, high
Low
protein.
glucose in the CSF fluid,
Yes, and
not
then high
in the
protein.
blood. And then gram stain, that just identifies our organism, right? So now we have an organism identification. Are you asking a question?
No.
All right. So for each assessment finding below, click to specify the corresponding disease process. Each finding may support more than one disease process, and each category must have at least one response. So look at your finding of fever. Do we suspect that with meningitis?
Yes.
Yes.
Do we suspect it with hydrocephalus?
No.
No. Do we suspect it with febrile convulsions?
Yes.
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 Convulsions. Do we expect it with meningitis?
Yes.
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 And we could, right? How
Yes.
about
Yes.
hydrocephalus?
Yes.
Yes.
And then how about febrile convulsions?
Yes.
Yes.
Those, you guys, you got two
Yeah.
right there given to you, right? Bulging fontanelles. Do we expect it with meningitis?
Yes.
Yes.
Yep. Do
Hydrocephalus.
we expect it with hydrocephalus?
Yes.
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 Do we expect it with febrile
No.
convulsions?
No.
No, we don't. Do
Leukocytosis.
we expect leukocytosis with meningitis?
Yes.
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 Yes. How about hydrocephalus or febrile
No.
convulsion?
No.
But
Right.
febrile, yes.
Febrile, yes.
Febrile, yes.
You expect a high white count with febrile convulsions?
No.
Febrile fever.
We don't expect it. They might have it, but we don't expect it.
Okay.
They can have a febrile convulsion without having leukocytosis.
Okay.
Okay.
I don't get the Prof. Please, I don't understand the bulging fontanelle with the hydrocephalus because the whole head is already big.
Hydrocephalus is fluid in the brain, right?
Yes.
And increased ICP. So
Yes.
that's going to give them bulging fontanelles, right? Sunken fontanelles are dehydration, but bulging fontanelles are increased ICP.
Yeah, I was thinking that already the whole head. It's not only part of the head. The bulging fontanelle is only at the fontanelle, at the anterior fontanelle.
That's why it's bulging.
That's what I am taking it. But for the hydro, it's the whole head that is big.
Yes. Well, yes, the whole head can be big, but it's fluid. It's caused by fluid.
Okay. Thank you.
So can there's a lot of background noise in somebody's. A high-pitched cry. Do we expect it with meningitis?
Yes.
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 With hydrocephalus?
No.
No.
Not sure.
Not sure.
Yeah, good
Not sure.
answer. Not sure.
Not sure.
So anytime we have increased ICP, we can have a high-pitched cry.
Okay.
Because
Okay.
remember, they're infants and that's how they're communicating to us, right? That cry is going to be changed, or they're going to have a change in that cry because they're in pain. Do we expect a high-pitched cry with febrile convulsions?
Yeah.
Yes.
Why would we expect a high-pitched cry with febrile convulsions? Does febrile convulsions cause increased ICP? No,
Stop.
No.
no.
Oh.
How about sunset eyes? Do y'all
Yes.
know what sunset eyes are?
Meningitis, yes.
Sunset eyes are when they gaze downward all the time.
Can you turn on the computer and type in my password? But
Can
don't
you
do anything, okay? It's
Can
just
you
that.
please mute the
Please.
background noise?
Yes, you can.
So sunset eyes, we're only going to expect that with what disease process? Hydrocephalus.
Hydrocephalus.
Yep. And microcephaly, where they have that enlarged head, where do we expect that?
Hydrocephalus.
Hydrocephalus. Yep. So there's your answers. Good job. So you should be going through those and asking yourself just like we just did. So our next nurse's note is at 1700. The client is currently receiving IV fluids and antibiotics. His seizures have subsided. He's still lethargic but arousable to stimuli. Respiratory status is stabilized. The client is feeding poorly through the NG tube, and the family is updated on his condition and reassured. So somewhere in between that time, he got a little worse, right? So take a look at your vital signs. Anything real concerning?
I don't know. My goodness, just Jim.
So the nurse caring for the above client understands that the client is at risk of developing which of the following long-term complications? Select all that apply so that we have more than one answer choice.
The hearing loss is confining.
Okay, so could a long-term complication be septic shock?
Cerebral palsy.
Well, let's go through them. Does anybody think septic shock is a long-term complication?
No.
No. Septic shock would be a short-term complication, right?
Yes.
Hydrocephalus, could that be a long-term complication?
Yes.
Yep. Because of that CSF, right? That inflammation, the scarring on the brain, the increased fluid, the obstruction of that CSF, the cerebral spinal fluid can cause
No.
hydrocephalus. How about cerebral palsy?
No.
Yeah.
Yes,
No.
it can.
Yes.
Yes, it can. The damage from that inflammation to the brain can cause neurological impairments leading to cerebral palsy, which is cerebral palsy is a group of conditions that impair motor and some sensory and muscle tone. How about hearing loss?
Yes.
Yes.
Yes. Hearing impairment is one of the biggest complications of meningitis. How about speech problems?
Yes.
Yeah. How about syndrome of inappropriate antidiuretic hormone?
Yes.
Yes.
Why?
No.
Not sure.
That's receipt. That is retaining
No.
fluid. Oh.
It's not affecting
No.
the adrenal
Yeah,
gland.
it's not going to cause SIADH.
Yeah.
So your correct answer choices are B, C, D, and E. So day 3 at 8 a.m., the client's condition has improved markedly. Neurological status has stabilized. He's alert but still fatigued. He's still receiving this ceftriaxone. He's currently able to feed and retain. No seizure activity noted, and the caregiver educated on the client's condition. So the nurse is educating the caregiver on the client's condition. Which of the following caregiver statements or statement indicates the need for further teaching? So it's a select all that apply, and we're looking for correct or incorrect answer choices. We're looking for incorrect answer choices.
B.
B is correct. My baby will never suffer meningitis in their lifetime. That is not correct. They may not get that same pathogen, but they can get a different strain of it. What about C? My other children will require post-exposure prophylaxis. They will, right? Because they've been exposed to it. So that's not correct. How about my child should complete the full course of antibiotics?
Correct.
That's correct. So that's not an answer choice. My baby requires a cerebral spinal fluid shunt.
Wrong.
No, shit, not necessarily, right? The child will remain in isolation until completion of antibiotics.
No.
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 So your answer choices for this question are B, E, and F. So that is the end of my presentation. Does anybody have any questions?
Thank you, Prof.
Thank you so much. Much grateful.
Thank you. Thank you.
Thank you
Only
so
question I
much.
have.
It's really
Thank
helpful.
you.
You
Only
are
question I
welcome.
have.
Thank you.
Thank you.
Thank
Joined
you
for the
very
first
much,
time.
Prof.
Thank
Good
you.
night.
Good. I hope it was helpful.
Yes, it
Very,
is.
very. Thank you so much.
Very helpful.
Good night. Thank you so much.
The only question I have is, can we get more of the case studies?
Well,
Yes.
That's all. Because everything
well,
was
that's
good.
what we're incorporating case studies each time. So
Hello, Prof. I have a question, Prof.
sure.
Yeah, so I want to know when it's safe or when the client cannot transmit in terms of meningitis. At
When
what
they're no
stage is
longer
it?
contagious,
Yes, please.
they're no longer contagious after they've been on the antibiotics for 24 hours, or if they've had after 24 hours of being fever free.
Okay, thank you, Prof.
You're welcome. Please, can we little bit about meningitis vaccines? What do you want to know about meningitis vaccines? So they're not recommended until the children are older. I believe they are adult vaccines. I would have to look that up.
You get it at 11 and 12 too.
Yeah, I thought they were older than infant and children.
Yeah. And then they get it again at 16.
Yeah, I'm looking it up from the manufacturer. Oh, so actually 2 years and older, they can get it. They get a single dose and then they can get a booster at 13 years of age and older who are at continued risk. So they have to be older than 2 to get it. The slides are shared. They're under previous lectures or previous sessions. They were posted prior to this session tonight. Any other questions?
Please, no, Prof. Have a good night, Prof. And everyone, sound sleep.
Thank you, you too.
Thank you, you too.
Can you put the link in, Professor?
I do not have the link.
The
Post them.
link for the survey.
I can have the administrative people do it. I don't have the link for the survey. Can you please clarify when meningitis is not contagious? So they need to be on antibiotics for 24 hours and they need to be fever free without medication for 24 hours.
Professor, is that going to be a high yield subject, meningitis?
It could be. I mean, it just depends. It has been tested on NCLEX.
Yeah, I only see a lot of ICP,
Right.
not really meningitis in general.
But meningitis causes ICP or could cause ICP. So It depends on where you are on that passing thing. Remember, it's an adaptive test. They said they will follow up for the link to be available from the next session.
Okay, thank you,
It's kind
Professor.
of hard to you know, we kind of cover everything broadly because there's no real, you know, I can't predict what's going to be on NCLEX, right? Because what I would be tested on, I would probably be tested on all OB stuff because that's one of my poorer subjects. It just doesn't interest me. So because it's adaptive, I would probably score low on OB, and that's what I would be tested on. But again, remember, it's an adaptive test. So where, you know, it's adaptive to individuals. I couldn't even predict what would be on it. I do know what students tell us are on it. My students that just graduated are beginning to take it, and they're telling me there is a lot of pharmacology and there is a lot of neurological. The two students that have let me know, that's what they got.
Professor, can we request maybe from the IT or whoever it is that write the program for us to get like an adaptive CAT that actually cuts off at a certain number, you know?
Well, your CATs have 85 questions. The
Yes, but
readiness assessment tests have 110.
yes, but I'm talking about with the same adaptive as the NCLEX where it cuts off at a certain time. Like 150 question put out there, but if you reach a certain where they say that you are passing, they will cut you off. Something like that.
Okay. I am gonna let the administration person answer that. I don't know that that would be
Yeah, Remar has
feasible.
that too.
I don't know that that would be feasible.
Yeah,
It might
yes, because there are other source that has it too, like
that
Remar,
has it. Okay.
Archer. Yeah, so and they give you 150 and it cuts you off to
Yeah,
know
nursing
how well
that
you're doing.
Okay. I can forward that on, and I am okay. It is being worked on. Probably I can follow up with progress and update on the same. Yes.
This is
So
a good idea.
Thank you,
yeah,
Fernand.
yeah. I believe in being exposed to so many questions. Yeah, the more questions you're exposed to, the more rounded you're going to be and broader because remember, NCLEX is broad. NCLEX is only testing that you can safely take care of a patient as an entry level nurse. They don't want you to be that ER nurse or that critical care nurse. They just want you to be a safe entry level nurse. The rest of it comes when you are out there in the field and getting your experience. Well, if there are no other questions, then I am going to say goodnight. And not necessarily the cat. Let's just study more, my humble thought. Yeah, that is a humble thought. You do have to study, unfortunately. Yep. I hope you all have a good night.